Hello, everyone. My name is Avery Dukes, and I'm the Community Impact Director at the American Heart Association here in Oregon and Southwest Washington. I'm so excited to welcome you to the American Heart Association's Health Equity Community Conversation, sponsored by Providence Health Plan. At the American Heart Association, we believe everyone deserves an optimal and just opportunity to be healthy, giving special attention to the needs of those at greatest risk of poor health. No one should be disadvantaged from achieving their potential because of social position or any other socially defined circumstance. We hope that today's conversation highlights factors that require specific attention to ensure equity and informs us how these efforts can make a positive impact on you and your community. Our two experts will be providing you with some context to the issue and sharing solutions we can all apply. Before I introduce them, we want to hear from you. Please share in the chat where you're coming from. Sacramento, awesome. I think we have some folks from Oregon here as well. That's great. Well, it's my pleasure to introduce Maria Chowdhury. Maria serves as a leader in health equity at Providence Health Plan. She's paving the path to a sustainable health equity roadmap for PHP with a vision to reduce and eliminate health inequities and disparities. She has an immense passion for healthcare quality and reducing healthcare disparities in the underserved patient populations. Prior to joining Providence, she serves as a director of quality improvement at Shasta Community Health Center, where she built a strong strategic vision and direction for operational and clinical excellence for the delivery of safe, equitable, and patient-centered care for vulnerable patients in Shasta County. Maria is also the founder of a childhood immunization coalition in Northern California called Shasta VaxFax. Currently, she serves as board chair for Clackamas County's Community Action Board, serving her local community and advocating for services and programs to improve the quality of life for low-income individuals and households. We're so excited to have you here, Maria.
Thank you.
Our other expert today is Christy Dorazo. Christy is the Director of Health Equity Strategies for the American Heart Association. She has served the association in various strategic planning roles over the past 26 years, including the creation of the organization's first health impact goals in 2010, the expansion of those goals in 2020, and currently the new and exciting goals for 2030. She led the formulation of the overarching AHA strategy or strategic value proposition, which sets a new direction and approach for achieving equitable health and well-being for all. We're thrilled to have you both here, but before we start, just one note for our audience. You'll all notice a Q&A icon in your menu. This is where we want your questions. Drop questions in the Q&A, and if we don't cover it now, we'll follow up in an email. And because this is a webinar, you don't need to worry about muting or unmuting, sharing, or anything else. Sit back and relax with your virtual friends. Christy, could you start us off with some insight about racial equity and what that has to do with health?
Thanks so much for having me, and thanks for the question. You know, I think that we've been watching the growing disparities gap for decades. Going back as far as the early 2000s, we hosted our first health summit around health disparities, specifically racial and ethnic disparities. And over the next 10 years, we actually saw that improve. We were very, very happy with trajectory of mortality and risk factor reductions, but something happened along the way. And suddenly in around 2015, we realized that the aggressive goals that we were setting for 2020 weren't being met for all populations. And we were actually seeing big, big growth in those gaps between racial and ethnic populations, those of different orientations, those with disabilities. And we realized that the life expectancy for many groups was actually declining over the decade. And that had us go in and look at, well, what's different? What's changing? And it led us to a 2015 scientific paper looking at social determinants of health and how the things that happen outside the four walls of the hospital were having a huge impact, especially on communities of color or orientation or even gender. We were seeing mortality rates for those populations going down. We were seeing huge disparities for Black maternal mortality. In fact, we were noticing that for Black women who had graduate degrees, they were seeing higher maternal mortality rates and lower life expectancies than white women who had high school diplomas. So we knew that something had to shift and had to change. And so we continued to look at those issues and began developing strategies around housing and around fair pay and around educational attainment. And then COVID hit and the disparities only became more pronounced. And we're looking now in 2022, and not only did life expectancy lower for all populations, but the life expectancy for populations of color decreased substantially more than their white counterparts. So that growing disparities resulted in a 2020 paper on structural racism. And if you want to bring up that slide, we can talk a little bit about what we mean by that as a root cause for these health disparities. So structural racism really is looking at the systems, the institutional practices, the business policies that affect all populations that are rooted in structural issues that may go back centuries, but are still manifest today. And I think that's the important thing to think about when we think about structural racism is one, it's systems and structures. It's not individual racism. It's not interpersonal racism. It's about the way our systems work. And that people are experiencing these today, even though they may have their roots in that historical legacy system, whether that be slavery, whether that be Native American boarding schools, whether that be Japanese internment camps, that all of those structural historical issues have ramifications for us today. I think an excellent example is highway construction, interstate highway construction that separated neighborhoods. And really, we now see that when neighborhoods were separated by that kind of construction, we resulted in higher levels of health equity. We also know that maternal mortality for Black women is 3 times higher than for their counterparts, and that if you live in a zip code that is predominantly a zip code of color, you're substantially less likely to get CPR. So all the data still points to these structural issues that exist and how that impacts our health outcomes and how we have to go above and beyond the clinical setting to be able to solve for this. Next slide. So specifically, AHA made these 10 commitments to how we're going to address the structural racism issues. One is an investment specifically in $100 million more in research funding, specifically for health equity. Similarly, another $100 million in new investments in our communities, primarily through our social impact funds. But I want to draw specific attention to commitment number 6, because we're going to talk about it a little bit later on. How can you drive health equity in the workplace? Because so much of what we experience in terms of health outcomes can be driven by effective policies that eliminate structural racism in the workplace.
Wow, that is great information, Christy. Thank you so much. Those were excellent examples. I personally had no idea about how race and location can affect our likelihood of receiving CPR. I don't know if that resonated with anyone else, but if it did, feel free to drop that in the chat or any other part of what Christy said. Maria, I would love to know how you've seen the impacts of equity or a lack thereof in what you do.
Yeah, so I would love to talk about it, as Christy mentioned, from a structural standpoint, looking at policies, practices, culture within an organization and how that changes in that and transforming how we operationalize our workings in an organization can help improve our members' experiences and their outcomes. So I want to take us to our Providence promise. At Providence Health Plan, we are really committed to reducing and really eliminating health inequities and disparities. As a part of an integrated system, we have the opportunity and presence to improve health equity for our members, for our caregivers, for our providers, and the communities that we serve. We have this as a responsibility to identify and address health disparities and to really tackle the determinants that Christy was talking about that are creating disparities in our communities. So we're doing a lot of different changes. We're focusing on identifying some social determinants of health for our members. We're closing the gaps, we're eliminating the disparities, we're trying to improve the outcomes for all the individuals. But at the same time, we're also really striving to make healthcare more affordable, more accessible. So our health equity program at the health plan is really integrated throughout the entire health system. It supports our members, it builds partnerships, and it's really helping to strengthen and formalize relationships with our communities and the people that we serve at the end of the day. And our health equity vision statement is listed on this slide. So please take a quick second to read through that. In the next slide, I would love to share kind of what our guiding principles are in terms of our health equity. But before I touch on that, I do want to make a quick note that Providence health equity is really central to our mission. This is the core of who we are. This is very closely tied into our mission, vision, and values. It has been since the Sisters of Providence came to Northwest more than 160 years ago to establish hospitals, schools, and orphanages. We are a fully integrated and open healthcare collective, and our population health initiative is really focusing on improving the wellness of every member in the community. So I want to take us to some of our 6 kind of guiding principles, our true north, I should say, when we think about building a roadmap for health equity, which is on the next slide. So looking at it from a structural perspective, when I said, impacting and transforming the way that we are in an organization, making health equity a strategic priority is extreme importance to Providence. This is a mission critical initiative. This is integrated, ingrained in all our operational areas in our departments. We want to make sure we build infrastructure to support health equity, which is data infrastructure, so we can understand our populations, whether it's race, ethnicity, cultural background, ethnic background, where do people live, their zip code, food insecurity, transportation needs, all that holistic approach to really understanding the multiple determinants of health. So we want to be able to build that infrastructure, then we want to be able to stratify our population and start understanding our outcomes, understanding lack of access that our members might be facing to better strategize our products and our benefit offerings. We want to make sure we eliminate racism and other forms of oppression by regularly communicating about this as an important mission critical issue within our organization and outside our organization. We also want to make sure that we are partnering with our community in an effective manner so we understand what's happening on the ground. And our ultimate future is to really, really get to a point where we have equitable access for all our members. On the next slide, I have some focus areas that I have identified. These are 5 important areas that we are really focusing on currently. Data infrastructure and reporting is something that I talked about. We are really looking into race, ethnicity, language, social, gender identity and sexual identity. We're also looking into doing more education and training and building capacity in-house for our employees. We're also looking at it from the lens of product and marketing and having more culturally competent communication with our members. With our network and community engagement initiatives, we are partnering with our community. We're looking at our incentive programs, we're redesigning them. And then ultimately, we are also tapping into access and expanding our resources for our members. Back to you, Avery.
Wow, thanks, Maria. It sounds like PHP has really robust goals. I love to hear that. So obviously, equity is an important piece of our lives. What can you each say about how it's realized in the workplace and beyond? Christy, would you mind sharing first?
Sure. We had an exciting initiative with our CEO Roundtable, which is 50 of some of the most prominent organizations globally. And we really relied on them and some of the best practices that they have to develop a set of 15 strategies you can use internally and 5 strategies you can use externally in your community to drive health equity in the workplace. And we really thought that in addition to the work that we were doing in the community and in research, that we really had to make sure that our house was in order too. And so that included adopting anti-racism principles that was just referred to, making sure that we have health literacy training, offering paid medical and family leave, ensuring a living wage was super important to all of the authors of this toolkit of driving health equity in the workplace. Employee resource groups, that's something that AHA is very proud of. We've increased the number of participants in our employee resource groups to 22% of our workforce. And we just won, I found out this morning, we just won a global award for the transformation that our ERGs have taken and the influence they have in our organization. So that, and as in addition to the culturally competent communications, we developed a language guide that guides us to make sure that we are being appropriate in how we work with our internal and our external audiences. So lots of different resources that are available in the Driving Health Equity in the Workplace that we'll make available to you in follow-up in the email.
Wow, it's clear that the AHA is really putting in the work. It's really great to see. Maria, would you care to elaborate on your end?
Yeah, and I will talk about it again from building capacity within organization. A lot of things that Christy mentioned, I would echo that. But in addition to that, I would say really thinking about ongoing employee education and training for things like implicit biases, having structured common language, understanding historical timelines and racial hierarchies. These are all really important concepts that we need to start talking about and allowing safe spaces for employees to have open dialogue. And this sharing of perspectives really helps change and transform that culture within an organization. And we know that implicit biases, because they're implicit at an unconscious level, do have an effect on our policies and practices and norms. So having robust education and training programs is really going to help us shift.
Yeah, one of the things we found and just completed our first session is around microaggressions, and how you may not even realize that the way you're saying something or your approach is a microaggression, and being aware of that is super important. So along with implicit bias, there's so much we need to learn that we don't know.
Yeah, and Christy, there's a question in the chat for you. I know you mentioned ERGs. Do you think you could share a couple of the ERGs that you found to be most successful or have a lot of interest?
We've had a number of ERGs that are super successful. Some are newer, some have been established a while. Our older ERGs, Heart and Soul, which represents our Black employee groups, and their allies. Our membership in an ERG is not specific. You can be a member of any ERG regardless of your affinity. And our Latinx ERG probably have the most experience in history. And then our Hearts with Pride, which represents our LGBTQ community, and they're actually doing programmatic work both for internal staff and external audiences. They're doing their own fundraising. And so I would say those three have been the longest standing and probably the most successful, but we do have a group around Asian Americans. We have one around introverts. We have a survivor and caregiver network. We have Parents at Heart, all of which have their own levels of engagement, and they're all very, very public facing to the rest of the staff. So they host their own events internally on a regular basis.
That's great. And for those of us who may not be involved in ERGs, can you give a bit more insight into what they look like and how they can help you?
Ours are structured pretty formally. They have leadership. They have a 5-member executive leadership board, a president, a vice president who would be the incoming president, a secretary, an events person, and then a liaison into the other ERGs. And so it's a pretty formal structure. They have a strategic plan that outlines what they'll do each quarter. And so then they have their membership, and that membership may range from a dozen or so people to hundreds of people. And again, they work on issues particular, like our Latinx group has been working on issues specific to immigration and how that affects health outcomes, regardless of where they sit in the organization. So they're taking on big topics and really are also content reviewers. Our Hearts with Pride did part of our review for our LGBTQ+ health disparities paper that just came out. And so they're really a very integral part. We try not to move forward with the content internally or externally without their advisement.
That's great. And Maria, I know that we've had a couple questions in the chat about things that you've seen effective in your own workplace. I would love if you could share on the Providence side what you've seen.
Yes, I would like to build off of what Christy said. We do have CRGs, but same kind of folks coming together. We have about 14 or 15, but I would love to know more about the introverts that you talked about. That perked my interest. But yeah, we leverage them a lot in decision-making processes. You know, it's a great group to get insights from, like from a process standpoint when we are thinking about certain questionnaires or certain things that streamline standard processes that we might be implementing that are member facing, it's amazing to run that through them and insights that we can receive from them. A couple of examples I would give you in terms of kind of thinking about that racial equity in the workplace. I think diversifying the workforce is such an important, I would say, focus area that organizations should have. And I know a lot are really moving the dial in this area. Really, even just starting with baseline data collection to really understand your turnover rates by race, looking at kind of your gender gap in your executive level, especially for women of color. What is a proportion of them represented? Interview standards, your hiring processes, standardizing them and helping to take out or eliminate biases within them are really some concrete, simple, short wins that you can implement to really start looking at this transformational work.
Those are some great examples. And one of the things that we found is implementing some of those, get rid of the bias on the front end of not putting someone's name on the resume that indicates their ethnicity or their gender, and getting them through the interview process without that bias. And ensuring we have oversampled for areas that we are deficient in. And so we were able to achieve last year a 44.5% diverse candidate pool, which was up from 33%. So intentionality does matter. And then we're hoping that that certainly ripples through the rest of the organization, including promotions and retention issues and getting into the executive level. So great examples.
Wow, thank you both. Do either of you have anything else that you would like to impress upon our audience and share that maybe they may not know about or you learned recently that has really made a difference for you in the way that you view racial equity in the workplace?
I think for us, one of the big milestones has been the creation of a practicing allyship series of learnings and workshops. And we presently have a group that's reinvestigating that, taking the content we developed in our pilot and then turning it into a mainstream AHA programming, which we've also offered to our outside partners, and really looking at allyship and using those representatives from the employee research group as liaisons to make sure we're not creating an allyship workshop in a vacuum, but they're really understanding what it means to be an ally to our Latinx colleagues, to our Asian colleagues, to our introverted colleagues, and not trying to invent the wheel, but having that co-created with them.
I will say, as organizations really think through this process, one thing that has really helped us is really to think about it at 3 levels. Really, the first is, what is your identity in this process? What is the scope of your responsibilities as an organization? What are your operations, your services that you provide? And start to define what your identity in this transformation work looks like. That's like the very first step, and that's where the cultural change aspect is so important. And then from there, go into the second step, which is then looking at your processes and then doing some short wins or maybe things that are easier to implement before getting on to sort of bigger changes. And then lastly, start thinking about what outcomes you wish to see. I think a lot of times we jump to solutions and we want to get to the outcome piece, but the process and the identity is really important in this process.
That's great, thank you. I definitely have never heard of those 3 levels before, so I'm really glad that you shared that. And thank you both. I think that's all I have today. So I really appreciate you both being here for this great conversation. And I want to say that today we only touched the tip of the iceberg on this topic, but hopefully we've all learned something new. I know I did, and we can use it to continue our journey to better ourselves and the communities that we're in. So thank you, Christy and Maria, and to Providence Health Plan for sponsoring the event. And of course, thank you to our audience for listening with open ears and for contributing in the chat. You've all been great, and I appreciate everyone's time. So I hope you have a great rest of your day.